Uh, Good morning and good afternoon, everyone. We are going to do one final test. Dr. Faisal Sultan, Honorable Minister, are you able to hear us, please? Dr. Sultan, can we do a microphone check with you, please? Dr. Sultan, if you could please connect to the audio, please. Good morning, everyone. We will be starting shortly. Thank you all for your patience. Good morning and good afternoon, everyone. We are still waiting for Dr. Sultan to join in. We can see him, but we are not able to hear him. So we will sort it out as we go along. But in the interest of time and for all of you present here, I'd like to start today's event. Good morning and welcome to the virtual launch of the UNAIDS World AIDS Day report, Prevailing Against Pandemics by Putting People at the Center. Thank you for joining us from all parts of the world. Before we begin, I would like to explain today's format. We begin with a conversation among key players in the global AIDS response, from civil society, government, donors, and the UN. And then we will open up for a dialogue of the speakers with the audience. If you would like to ask a question, please type your question into the chat box. For members of the media present today, please help us identify you easily by indicating your name and media outlet in your Zoom identity. To do that, for changing your Zoom identity, please click on the participants list, identify your device, right-click, and click on rename and type in your name and media. We also encourage the audience to use the chat box for your comments and questions. Our discussants this morning are Ms. Winnie Byanyima, the Executive Director of UNAIDS, Ms. Maureen Murenga, the Executive Director of Lean on Me Foundation in Kenya, and Dr. Faisal Sultan, the Minister of Health and Special Advisor to the Prime Minister of Pakistan. We also have a video message from Ms. Sigrid Kaag, the Minister of Foreign Trade and Development Cooperation of Netherlands. Next year, we will be completing 40 years of AIDS. We have come a long way since then, but AIDS is not over. And with COVID-19, we face a dual colliding pandemic. This World AIDS Day report is about how the AIDS movement has faced COVID-19, but more importantly, what we are aiming for the future. We begin today's conversation with a video message from Minister Kaag of Netherlands.
It's a pleasure to be here today at the virtual launch of the World AIDS Report 2020. Let me begin by thanking Executive Director Winnie Byanyima for highlighting the importance of global solidarity. We need this now more than ever. Because if we are to end the HIV pandemic by 2030, just shy of a decade from now, we need to get the global HIV response back on track. And the best way we can do that is through shared responsibility. The current COVID-19 crisis shows why solidarity and responsibility matter. As with HIV/AIDS, the heaviest blows fall on the most marginalized communities. This in turn places a great strain on health and community systems, and it makes fighting pandemics even more difficult. So whether as a global community or as individual countries, our best responses to any pandemic are a strong and inclusive health system response and resilient communities capable of absorbing shocks. This is true of COVID-19, it's true of HIV/AIDS. The World AIDS Day report, launched here today, presents the new proposed targets for the new global AIDS strategy. UNAIDS has developed an inclusive and genuinely consultative process, which will lead to that new strategy. It includes the advice to direct money and energy towards the people most at risk of HIV. This is sensible and effective advice, and I gladly endorse it. Only recently I was shocked to learn the results of a study commissioned by the Netherlands. Only 2% of AIDS funding worldwide targets those who are most at risk. But most new infections happen in these key populations. 62% of new HIV infections are among gay men, sex workers, drug users, and transgender people. How can we end the HIV pandemic, or any pandemic for that matter, if we ignore those most at risk? Stigma and criminalization impede access to medical services. And this is exactly how pandemics continue to spread. I call on all 11 UNAIDS co-sponsors to support the broad implementation of the new global AIDS strategy at UN, country, and community level. We need to show true global solidarity with those most at risk from HIV and AIDS. This means taking measures that are actually effective and helping communities find solutions that work for them. After all, you know what they say, nothing about them without them.
Thank you very much, Minister Kaag, for highlighting the need of global solidarity and for inclusiveness in responding to global health and AIDS. I now turn to Maureen to kickstart the conversation. Maureen, over to you.
Thank you very much, and thanks for the beautiful speech from the Netherlands, and thank you for those who have joined us. My question is to Ms. Winnie. The report shows that the AIDS response is off track, and the 2020 targets have not been met. What's the catch-up plan? How can we catch up?
I'm delighted to be here and at this launch of the World AIDS Day report by UNAIDS. You're right, Maureen, that the targets, the 2020 targets, have not been met globally. But our world has been transformed over the past 12 months. This World AIDS Day feels very different from past ones. COVID-19 has worsened the inequalities that have been driving the HIV pandemic. We see now the close link that exists between our health and the health of the global economy. Who knew that we would be here because of a virus? We are in a world where now the HIV epidemic, the gains that have been made over the past years are threatened. In many countries, HIV services have been disrupted, supply chains for key commodities stretched, and we see this. UNAIDS gathers the data, and we can see it. Around the world, fewer people are being diagnosed with HIV because diagnostic centers are not working as regularly. Fewer people living with HIV are starting on treatment, and prevention services have also been hampered. The scale of HIV treatment was 50% lower in the first half of 2020 than in the first half of 2019 because of COVID. So the COVID disruptions cannot be taken lightly. We did some modeling in the beginning of the COVID crisis. We had a lot of fear that the disruptions were going to cause major reversals. Thankfully, we've seen countries coming back and closing some of the gaps that were opened immediate in the first months of the crisis. But we are still seeing disruptions, and we are still seeing that the gains, the speed at which we were last year has slowed because of COVID. Our new report, which we are launching now for World AIDS Day, Prevailing Against Pandemics by Putting People at the Center, presents a way to navigate the difficult times ahead and to get through the challenges, to beat COVID and beat AIDS. But even before the arrival of COVID, we were not on track. The AIDS response was failing. We had nearly 12 million people out of the 38 million people living with HIV who were not on treatment. Stigma and discrimination was still rampant. We had new infections, 1.7 million new infections last year, 690,000 AIDS-related deaths last year. All these way above the 2020 targets. So, but this picture shouldn't make us hopeless. There was also progress. That's the global picture. But if you look underneath, you do see that progress was happening in some parts of the world with respect to certain groups of people. For example, in Africa. The region that was making the fastest progress was Eastern and Southern Africa, the region with the highest burden. And in that region, a country like Eswatini, small, landlocked, poor country, met all the targets. Botswana did. It ages well. Countries such as Cambodia, very close to the 1990. A country like Thailand had met the goals. So we see that it's possible, it's achievable. So what do we need to do is your question. What do we need to do to get ourselves back on track? We were not on track before COVID, and COVID is blowing us further away off track. How do we get back? UNAIDS is proposing new targets to take us forward, to remobilize us. We want to look forward, to be bold, and to reset those targets so that we double up and we catch up. So we are proposing a new set of targets for 2025. These targets are holistic. They focus on a very high coverage of HIV and sexual and reproductive health services, together with the removal of bad laws and policies and on reducing stigma and discrimination. These targets also focus on reducing the inequalities, which are the drivers of HIV and also drive COVID-19. The targets will push us to put people at the center. That's critical, especially those most at risk and marginalized. In this region where I am right now, Eastern and Sub-Saharan Africa, we have to put young women and girls, adolescent girls, at the center of our response. We have to put sex workers at the center of the response. After all, with sex workers, we've hardly made any progress in the last years. Transgender people, the same, very little progress. People who inject drugs and gay men have to be at the center of the response, particularly in regions such as Eastern Europe and Central Asia, regions such as Latin America, because they are the ones most left behind, gay men and men who have sex with men. So it's going to be about getting the most vulnerable, putting them at the center of responses. It's going to be about fighting hard on the side of prevention. Prevention has been lagging treatment. We've got to put more effort there. We're going to have to be more focusing on the hotspots, not choosing what we want to address because that's what we are comfortable with, but being evidence-based, targeting closely where the risk is, not where we don't want to see. So it's about the hotspots, it's about being more targeted, it's about the vulnerable people at the center of the response. It's about tackling the drivers as well. By not addressing the drivers, we shortchange ourselves, we bring the biomedical answers, but the drivers continue bringing more people, new infections, keep piling in new infections because we don't tackle them. We have to tackle the drivers, the social barriers, the human rights barriers. In brief or in long, those are some of the things we're going to have to do, but above all, what will bring us back on track is to reset our targets, make more ambitious targets, but realistic ones, and rally and do those things that we know work, that have got us up to here, but take them to scale. That is how we will get back on track and beat AIDS and beat COVID, because both are pandemics and we need the same approaches to win. I would like at this point to ask a question to my fellow panelists, Your Excellency, Faisal Sultan. Thank you for being with us, for making the time. We have seen that prevention efforts are lagging behind. As I've been saying, they lag behind our treatment efforts. What can governments do to stop the high levels of new HIV infections? Give us the example from your country. How can we maintain the momentum for fighting AIDS during this COVID pandemic? Thank you, Excellency. Over to you.
Thank you very much. I will give you a brief overview and then specifically address the specific questions that you mentioned as well. But first and foremost, I'm tremendously honored to be here and to be part of this global launching for the UNAIDS World Report for this year. It is an important event in any case, but I think during the current COVID crisis, it highlights and focuses on the tremendous importance of the need for continuation of many of our services, which indeed serve some of our most marginalized parts of society during the COVID crisis. And this is a dual challenge that I think everybody has been faced with. So I'll talk a little bit about that. But to begin with, let's talk of how we get Pakistan on track and how we bring our numbers and aims and targets in alignment with what we wish to be with. First of all, Pakistan has affirmed its commitment to the 2030 Agenda for Sustainable Development, and especially through goal number 3, which of course talks about health and well-being, and then specifically focusing on to HIV, AIDS for subsections 3.3. And the way we are going about it, and we feel that this is the way to move forward, is to make sure that this is mainstreamed, that HIV care, prevention, treatment, the whole spectrum of care is completely woven into our thread of medical care delivery. In view of the seriousness of this matter, what we have done is that we have initiated universal health coverage discussion, and we have actually adopted this. The benefit package for Pakistan and the essential package of health services now actually include HIV as part of the community and primary level interventions. These include things like HIV testing and counseling, as well as referral, provision of syringes and condoms for high-risk populations, health education on sexually transmitted infections. In fact, tomorrow we are launching our national STI guidelines. So the primary healthcare center level interventions are primarily at rural health centers and probably at GP clinics. And these will include, of course, HIV testing, counseling, and referral for antiretroviral therapy, partner notification and expected treatment for STIs, as well as referral for HIV available at the community centers. We would also be screening for HIV at tuberculosis centers, as well as to screen TB for all newly diagnosed individuals with HIV and their close contacts. So this work is really just the beginning, to be perfectly honest, but it is part of a global reform process that the government of Pakistan has initiated. And our aim and objective is that we have a set of interventions that really hit at the root of some of our healthcare problems, and to actually address it in a harmonized, synchronized fashion through our primary healthcare network, instead of things or actions or interventions that are useful perhaps in the short term but not sustainable. And I think this way, this addition of these interventions into the benefit package of our universal healthcare intervention will indeed ensure that we bring back some of our targets into focus and to enable ourselves to reach them. I do feel that additional interventions, including trying to bring in and across the board use of opioid substitution therapy, which is something that we have lagged in so far, as well as to ensure that those in care are actually on treatment and are suppressed, And so those targets are much better met once this whole process is interwoven into the larger health system instead of being an exceptional standalone delivery mechanism. So in a nutshell, the incorporation of HIV care, the entire spectrum of it, into our primary healthcare system, all the way from home care into perhaps all the way to tertiary care, this is the way we feel we will be able to reach our targets. I'm grateful again for this opportunity to share my views, as well as tremendously honored to share the stage virtually, albeit with such eminent people. Thank you very much.
Thank you, Minister. Is it now my turn?
Thank you very much, Dr. Sultan. Maureen, Dr. Sultan talked a lot about what the government puts in place. And one of the key aspects of the AIDS response is the involvement of civil society. How can governments make space for civil society?
Thank you very much. Yeah, I know it's globally known that without actively involving the civil society. And government efforts are huge and we really appreciate them, but they're not sufficient to achieve the success in HIV response, especially among key population and other marginalized and stigmatized groups. This is where the role of civil society begins. But we have seen that sometimes the civil society are becoming less able to play their roles because of the tightening political situation, reduction in overseas funding, and we know that governments can actually play or create an enabling environment for civil society working with key and vulnerable population to play their role and to support their peers to access services. And we've had some tension. It's not been a really easy partnership between civil society and government in some contexts, because sometimes our roles include maybe monitoring or what we call community-led monitoring, where we sometimes get ourselves criticizing some of the services or some of the people providing the services. But we feel that this criticism should be taken positively as a way of giving honest feedback that can improve quality of services, but not as a way of creating enmity. There's also a need for genuine capacity building, co-funding for civil society organizations, better governance and networking, but these are always funded by external donors. It would really be good if we see some of these resources coming from our governments as part of acknowledging our role in the response. And also there's need for inclusion of the CSO contribution in government progress reports. We do a lot of stuff, especially in terms of ensuring access, retention, and adherence to services, addressing human rights barriers, addressing gender equality. But when those successes have been done, we are never acknowledging these national reports. So I think this could be one way also of strengthening our partnerships in the response. And then I'll conclude by saying that true partnership of civil society and government should be one of equal partnership. Our roles may be different, but they are complementary. And that is what makes the HIV response successfully, when all of us together play our roles the best way we know how. So we are partners and not enemies, and we can work better together if we get a lot of support from our governments. Thank you.
I want to make some additional comments to what you've said. I concur with you. This question of shrinking civic space or shifting civil society space is one we must unpack and understand if we are to take forward our work to fight AIDS. Why is the space shrinking? Or is it shrinking? Or is it shifting? I think it is both. But why? You need to see the forces. One, there has been a big force of conservatism around the world that has pushed back and continues to push back very hard on human rights, and particularly women's rights, pushing hard on issues such as sexual and reproductive health against the gains made there, pushing back against things like comprehensive sexuality education. This is our battleground. This is what we know works for HIV, but we've got conservative forces against us. We have conservative forces that are, actually, they have framed this as cultural wars, because there is strong opposition in many of our regions with HIV against the rights of LGBTQI. That's where our criminal laws are hardest and we are not making a lot of progress in the repeal of those laws. So we have to understand this conservative backlash and see how to address it. I think such forces can only be rolled back through movement building. We cannot hope to have an open space there unless we mobilize people and change attitudes. Sometimes I think we leave that to others and think we can solve the problem of HIV/AIDS through a biomedical approach. We can't. There is no treatment, no pre-exposure prophylaxis or ARV or whatever that will reach the hands of a gay man in my country, Uganda, while the criminal law is enforced in a harsh way. So we have to push back against conservatism that is really entrenching and making it harder and harder to move forward on women's rights or on the rights of sexual minorities. I say this very, very sincerely, because without making progress there, pushing back against extreme conservatism, we will not end AIDS. Then the other force that I see that's very important to address is the contestation about, oh God, why do you put this in my legs? Around liberal democracy. We have a serious pushback against certain models of democracy that we have taken as a given since the end of the Cold War, that multipartyism, freedom of the press, freedom of association, all these are in our laws in many countries, but are now contested with more powerful countries in the South saying that this doesn't work. So you get models that are not actually, that are pushing back against what we are used to, a free media, freedom of association, freedom of speech. These are also under attack. And I think that for us, if we want to fight AIDS, we do need to protect those core tenets of a liberal democracy. So we can't work in a vacuum. I put those on the table too as contextual issues that are making our work harder and that we must unite with others to address. But I want to come back to you, Maureen, with a question, because I want you to tell us, as someone on the ground, how have communities been coping during COVID-19? And by communities, I'm asking particularly about the key populations and adolescent girls and young women. How have they been coping to take our work forward? What are the mistakes that you are seeing or you have seen in our struggle for HIV that should not be repeated now in fighting COVID? Tell us a bit about your COVID experience as an HIV activist on the ground.
Thanks, Winnie. Actually, I'll approach this as an advocate and also a person living with HIV. And we have, in fact, like the rest of the world, we were shocked. We didn't expect that this COVID epidemic was going to spread that fast and lead to a total change of lives. And so the first thing that happened were service disruptions, because each and every country was trying to control, and then there was lockdowns. So our health system is structured in such a way that you have that one particular facility where you get your ARVs and other services. So if you are not in that facility, then you needed to go through a process to get your medication. And we got people missing doses of their ARVs. And worse still, we got the prevention services completely gone. I mean, it was enough that you're going for your ARVs and you had to go fewer people because they were minimizing the numbers, and then you couldn't ask for anything else. And so the focus was giving multi-month treatment to people living with HIV, even those that needed to be seen regularly. But on the flip side, people missed on testing, especially pregnant mothers. Most of them did not get the HIV testing, and therefore, when now they are getting to test, sometimes it's a little too late. We did not get the prevention services for adolescent girls and young women because the PrEP wasn't a priority in this time. And then we had now the challenges of also our people from resource-constrained areas and the adolescents who did not have masks. It is not obvious that everyone would afford to get their own masks. And so they would go to facilities and they are turned away just because they didn't have masks. So what we did as communities, we had to really quickly think through, and we got support from UNAIDS and others and Global Fund, where we were providing masks for our people to attend services. We did a mapping to see who was missing out on treatment. We had our own safe spaces where people called for. It was so difficult, especially I had like 3 foreign friends who found themselves in Kenya during the Nairobi lockdown. They could not go back to their countries. They needed their ARVs, but they were not in the system anywhere. So every time you went looking for treatment, they would ask you, from which hospital is this one? So I think those kind of boundaries that we have put in our health systems were some of the issues that really affected access to services. Then we had now healthcare providers being supported with PPEs to continue in services, but we forgot that we have peer educators, we have mentor mothers who still needed to reach out to communities. And so we got a little support. It isn't adequate up to now to protect our peer educators, our mentor mothers, so that we continue in providing services as community members. Because key populations, men who have sex with men won't go to the health facility, to the traditional health facility. They're criminalized. They have to be reached out by their peers like we traditionally do. We have to protect these peers. We have to support the mentor mothers to reach the pregnant women living with HIV who need services. And then we had COVID stigma. Some of our facilities were changed into COVID centers. And of course, everyone who had COVID or suspected to have COVID went there. So it was difficult for some of our members to actually just walk there with a reusable mask as the only way of protection. So we saw a lot of them actually seeking for the community health workers to bring their drugs to where they were because of that scare. And that conversion also reduced the number of people who are attending to people living with HIV. So you'd go to hospital and it's a number of you with very few people to attend to you. That shift, that focus of shift from HIV to COVID has actually really affected us in a number of ways. So what we need to do is that in as much as we prioritize COVID, and COVID is going to be with us for a long time, we still need to remember that HIV is still an epidemic. It still doesn't have a cure. It is still stigmatized, and therefore it needs the attention that it deserves. And now that the report shows that we are off track, you can't just do things the normal way. We need to really have strategies to ensure that the service continuation, both of treatment care and support, as well as prevention. Then most countries are being told to do differentiated service delivery, but the community centers have not been strengthened to take up the services that they need to play. So much is going to healthcare facility, Not so much resources are going to community facilities, yet the task shifting is supposed to happen. So I think we need to put our resources where our mouths are. And if we are talking about community systems for health, then these need to be given adequate resources. Community engagement in the COVID response wasn't as much, so there we lose an opportunity. We know what community engagement has done to the HIV response. I think engaging communities in the COVID response there would be a lot of learning. And one of the things, there's a video I saw, Ms. Winnie, you did about ensuring that the COVID vaccine reaches everyone who needs it when it's out. I think this is one of the greatest lessons we need to learn. And we can only do that through advocacy, through community engagement, to ensure that people are aware and they are demanding. Otherwise, it will be a vaccine for those who are able to, and a vaccine for the rich, but the poor will still be dying. And we saw that a lot when we needed the ARVs to reach Africa. And then another lesson we learned is around data. If we can get daily data on COVID-19, then I think we should also be getting daily data on HIV and the other epidemics, because sometimes we have very outdated data. Sometimes the data is not better disaggregated. We can't tell what the different populations are going through. And then finally, I'll talk about the young women and girls. In every epidemic, usually the women and the girls suffer disproportionately. And in as much as we knew COVID-19 is an epidemic, we didn't prepare well in terms of ensuring the gender issues don't rise. We have seen an increased number of our adolescent girls that we kept in school to prevent new HIV infections, now out of school, and there's increased reporting of teenage pregnancy, early marriages, and female genital mutilation. I think we need to do better. We need to ensure that we don't have this repeated every time. We already know that epidemics come disproportionately for women and girls. I think all our epidemic response should be very sensitive to this. So I could talk about this for the whole afternoon, but because of time, I'll leave it there. We still have a lot to do to ensure service continuation. We still need to ensure that within this epidemic, our women and girls are protected. And those who are out of school, we find a remedy for ensuring that gender-based violence is reduced and they are protected. And so just to move us on, I have a question for Dr. Sultan on the right to health. So how can governments implement the right to health? How can the burden on people for paying for their own health be removed? Because now we are supposed to pay for COVID-19 and most of us cannot afford. So how can we address some of these? Thank you.
Well, I think the short answer is by putting it in budgets. But the fact is that there is a global expectation. And I think it is part and parcel of every responsive democracy to at least ensure that the poorest parts of society are being sorted as far as healthcare at least is concerned. There are other parallel interventions that are going on in Pakistan at present, which I think will serve as, I would say, empowering steps to reach all sorts of universal cover, whether for inpatient care or ambulatory services and so on. But I think the shortest bit is this: a government that is responsive to the needs of its population just cannot simply ignore these basic things. Healthcare, catastrophic healthcare, impoverishes people, and a lot of preventable and treatable diseases hold back people from competing, or at least having a reasonable fair chance of competing in the economic opportunities that any country has to offer. And we are those countries that are not able to do this, essentially are not able to empower the lower sections of their society, those that are disadvantaged in one way or the other. And I think healthcare and education, of course, are the grand equalizers. So I think it has to be reflected. If somebody asks me, I say, well, show me the government's commitment, show me how much money are they willing to put forth for this thing. And at our end, we are trying our best. The Prime Minister in his inaugural speech showed a CT scan of a child with malnutrition and stunting. And for this to be in an inaugural speech, meant something. And we keep reminding him, and he remembers, and he feels that this is a human rights issue beyond anything else. So I think the political commitment, and then followed by monetary backing of such programs, is the key to this. And in Pakistan, we intend to make sure this happens by underwriting many of our important programs, from tuberculosis to HIV to malaria to malnutrition. All these things need to be addressed, and many get addressed in a very similar fashion, as I mentioned earlier. So hopefully that answers your question.
Thank you very much, Dr. Sultan. Winnie, the AIDS has shown that the interconnectedness of the world, and with COVID-19, it has exposed what happens when we don't invest in health. How must the world change with respect to global health?
Well, thank you for that question. We are in a global crisis, and we must learn lessons from a crisis. Certainly, one of the lessons we learn is that the connection between our health and the economy is tighter than we had ever thought. That's an important lesson, that our health and the health of the economy are closely linked. The underinvestment in health, the underinvestment in social protection has got us where we are. Had we had stronger health systems, stronger social protection, we would be in a better place. So investing in delivering on the right to health, investing in social protection are not things now that we can look at as also good to have. We must see them as essentials, even in order to have a healthy and strong economy. You know, the right to health was something that many countries worked on and ensured that governments delivered to all people their right to health. And this often came from crises. We see in Europe, for example, that coming out of the Second World War, European countries built their welfare states where everyone had a right to free health care provided by the state. We saw that. They built these strong welfare states, at the core of which were certain services that were public goods, like healthcare. The same with a country like Korea or even Thailand. Thailand was emerging from an internal crisis, a civil war, and built its system now based on public provision. Public provision. Almost more than 90% of their healthcare system is public provision. And it is now the capital where people go for health tourism, because the system is so good and it's based on public provision. But we have come to believe, and we have bought a neoliberal message that governments can't afford to deliver right to health, let the private sector deliver it. Well, this is where it has found us, with systems that are fragmented, that are driven by profit seeking rather than the health needs of people. So I think we have to rethink how we are going to achieve SDG 3 and reconsider this presumption that the private sector will deliver where the state can't. We must say the state can deliver and go back to find out, how do you raise enough resources for the state to deliver? That's another question, not for today. But coming to access to medicines, same thing. We as governments, as countries, gave up this obligation to produce and distribute medicines and passed it on through World Trade Organization rules to the private sector, such that the development of medicines is being driven by profit, not the health needs of people. Now, when we're in a crisis, what happens? It is not the private sector. The governments are not sitting there waiting for companies to find the vaccine. No, the governments have put the money down and said we must get the medicine. We need the vaccine to save our lives. So the whole system based on profit-led innovation has collapsed in a crisis. We now see the need for the state to drive innovations to regulate the production of medicines and their distribution. So I'm seeing a whole new, a reset of how the right to health is delivered globally, that we must go away from these assumptions that we can hand over to profit seekers the production of medicines and the delivery through health systems. The role of the state of governments is critical. I think that's an important lesson. But going further, I see that now the lessons from the HIV experience are relevant today, and we must now build on them. The fact that health should be in the hands of people, that communities need to be at the center of any system that delivers health. Communities gave the success of HIV. You need now communities to fight COVID. Many countries who saw it quickly and came and mobilized the communities that HIV movement had mobilized are even doing better in their COVID response. So building health systems where communities lead and use their capacities, their knowledge, their cohesiveness, their voluntarism to prevent disease, to be prepared for epidemics, to come in and do what's needed. This is a major lesson, and we want, coming out of this crisis, to have governments now investing in this infrastructure of communities and giving communities the means to lead in the delivery of their own services. This is part of what comes from HIV. And I think this crisis has brought it forward. We also see that human rights are critical. They're at the center of fighting and winning against a pandemic. This is a lesson from HIV, that if you don't start by finding those whose human rights are denied, those whom inequalities drive to the margins, that your crisis, your pandemic remains with you. You need to start with those left behind. You need to start because the epidemic moves along the cracks of inequality, the cracks of human rights gaps. You start there in order to win. I think we learned that in HIV, and it's becoming important to recognize that in order to win against COVID. So those are some, for me, the things that the world has to, coming out of COVID, take care of and adapt to. Revise the way we produce and distribute medicines and regulate it, put in the role of the state and the money of the state. Strengthen health systems and put public provision as the main driver of health systems. Yes, the private sector comes in, but not to be the main deliverer. And then also build preparedness and prevention by investing strongly in communities and respect human rights and non-discrimination. Those are some of our lessons from HIV that I think that the world must learn and take forward. Sorry, I've been long.
Thank you, Winnie. I'm now going to widen the conversation and bring in a few community voices. Three of them, one from Eastern Europe, one from South Asia, and two from Africa. In fact, so first I'm going to move and call on Yaduvendra Singh, who is coming to us from India. Yaduvendra, you have a question and a comment.
Hello.
Yaduvendra, if you can unmute yourself, please.
Yeah, can you hear me?
Yes, we can.
Yes.
Yeah, hi. Hi, this is Yadvin. I come from India and I belong to MSM community. So I just want to say that in India, we have seen the response to HIV has mainly been driven by the community-based organizations. But now with the current national programs being in place, the role of CBOs, community-based organizations, have been cut very hugely, very like big time. So I just want to know what is the UNAIDS strategy of having strategic engagements with the government to stress the importance of the fact that the HIV program should be led by the community. Thank you.
Thank you, Advendra. I'm now going to go to Yana Panfilova from Teenergizer from Eastern Europe and Central Asia to ask the question before I pass it back to the panelists to answer. Yana, over to you. Welcome.
Thank you very much. Welcome to all of you, and thank you, and happy to see you all. So, like, situation in HIV in ICA region remains challenging along with the political, economy, social, and COVID crisis. Unfortunately, young people are not priority for our governments in ICA region. So, I have a question for: will young people in ICA region be prioritized in the new UNAIDS strategy? Thanks.
Thank you, Yana. Now I'm going to call on Afia Simapande from Zambia, who represents the Athena network in Zambia. Afia.
Thank you so much for that. So I have a question for Ms. Winnie. It's a privilege to meet you again virtually. So my question is that how will the new UNAIDS strategy ensure that funding is made available and less restrictive for all grassroots organizations, youth-led organizations also, implementing programs that help adolescent girls and young women living with and affected by HIV, even those in hard-to-reach places, so that no one is left behind? Thank you.
Thank you, Afia. And the last set of questions before I turn to the panel is from Dr. Vatiti from Uganda. Dr. Vatiti, can you unmute your microphone, please? We seem to have issues with the connection, so we'll get him back again. But let me turn these three questions over back to the panel. First, Winnie, for you to respond.
Well, first about this, our UNAIDS strategy. It's not really a UNAIDS strategy, it's a global AIDS strategy. So that's an important point, that we are developing a strategy with so many stakeholders, including you, Yana, and many others. We are consulting to make a strategy for the world with targets, global targets, but where each country will pull out and set in its own context. So that's an important point. Now, you ask about young people in that strategy. That's a very good question, because this HIV pandemic is into a second and even third generation. And the issues for each generation keep shifting. By issues, I mean even the attitude of different generations towards the disease keep changing. When I see the young generation in my country, they see HIV just as a chronic illness, like diabetes, like hypertension. They have no sense that actually it kills. They think that you just live with this and die of old age, because they never saw the deaths. I saw the deaths. I buried my brother and other people close to me. And I went through that time when the deaths were at the peak. So you find that one generation, another generation, even in terms of how they see the disease, is different. Then you see that young people, the risks they face are different from the young people of the other generation. The threats, the avenues of risk are also different. So we need to focus on the fact that young people are so much more vulnerable today. And we need to make sure that within that, adolescent girls are also a primary focus in certain regions where their vulnerability is much higher, like here in Africa. So yes, our strategy is pointing in that direction of putting a strong focus on young people, on pushing for services that work for young people, organizing around prevention that works, that addresses the vulnerability of young people, and services for testing and treatment that work for young people. So you will find that our strategy does have a youth lens and a gender lens. And it's for you to make it more so. The strategy is still being formed. So it is for you to stay on course up to the end, ensuring that we get it right. The funding is different. Funding is going to be, the issue of funding community-led services is going to be fought and won at the national and even subnational level. We will focus on financing, definitely. We are costing, we will know the gap that exists. We have always counted, we know the gap, we know what's needed for the global response, we know what's available, we track all that. And we speak about the gap and the cost of underinvesting, the cost of failing to deliver on prevention, what that means for the future in terms of new infections, in terms of even deaths if you don't put people on treatment, and so on. We do the costing, but ultimately, the fights are going to be won at the national level. I'm going to build a team at UNAIDS that I want to have the capacity to work with governments, particularly the lower and middle income countries, to work with them the journey of building the resource base so that they own their own response, so that they move away from over-dependence on donor money, on aid. But ultimately, for those resources to go to communities, to community-led services, we are going to fight these battles country by country. We're going to show the evidence that we have that shows that community-led services deliver best, that's how to reach everyone and no one is left behind. That is an advocacy battle that I want to join you on. I know many of you are fighting this and I'll be with you there. There is a commitment of a quota that should go to community-led services, and I don't think that many countries are achieving that quota. So it's about advocacy in the country to ensure that resources, particularly domestic resources, a good share goes to community-led services. That's what I want to respond to those two questions, and leave space for others to respond to them too.
Thank you very much, Winnie. Would Dr. Sultan or Maureen want to weigh in, please? And then we have a question from the media waiting for you. Okay.
I think one of that, what I would want to comment in that was just mentioned by the young girl from Zimbabwe is around making the resources accessible. The resources that come to our countries, they put very difficult parameters for people who are working with the hard to reach populations, and for the young people to, or young organizations to access. So I think it should be simplified, especially for those targeting youth and emerging networks, should simplify the application process as well as the reporting process, because some of these organizations are doing a really, really amazing work with the very difficult to reach populations. But because they don't have that high class, first class office and infrastructure, then they don't get the resources. So this kind of mentality should reduce. In as much as we have a lot of emphasis on value for money, we should also have a lot of emphasis on value for life. Thank you.
Well said, Maureen. Our next question comes from Ola Al-Ghazawi from the Science Development Net. Ola, you have the floor, please.
Hi, thank you for the very informing session. My question is for His Excellency Dr. Faisal Sultan, because he said that Pakistan was able to integrate HIV care in the healthcare system, and that helped a lot in decreasing the prevalence of the new infections. But as an Islamic state, and I'm based in Egypt, Cairo, so we are the same here. How were you able to do that in the light of criminalizing key population that are at high risk of getting HIV and putting them in jail if they came out, like men who are having sex with men and sex workers? So how did you deal with that in Pakistan and manage it to decrease the prevalence of HIV? Thank you.
Thank you, Ola. Dr. Sultan has just stepped out, so he won't be able to answer the question, but let me turn to Winnie to kind of, in a broad stroke, answer some of the key issues you raised about key populations. Winnie, over to you.
Okay. The issue of, first of all, in the whole global response, we know that while we were making progress on testing and treatment, putting people on treatment, we were making less progress. We are making less progress on prevention. When you look at why are we making less progress on prevention, you see that across the regions, but particularly certain regions, that the new infections are coming from key populations. When you look at Eastern Europe, Central Asia, MENA region, Latin American region, and Caribbean, the new infections are mainly key populations. So what does that tell us? What is the driver there? Because the science is there for prevention, the biomedical tools are there, other tools of prevention are there, then there's also the testing and treatment. It is to do with the social barriers. It is to do with the human rights barriers, the criminal laws that are enforced harshly in many countries, the stigma, the discrimination. That's what drives LGBT people underground and not come up for health services that are their right. The same with people who inject drugs. It is for the criminal laws, the criminalization of personal use of drugs and harsh enforcement of those laws. So we have to work on the human rights barriers. We can't just say that, we can't hope that we'll find the solution just in the biomedical solutions. The pills, the condoms, they are there, but they will not be the ultimate solution. We have to work on the human rights barriers. We have to decriminalize.
But there's still people who don't believe me. So this is for you. Listen up.
Okay, we must decriminalize. The laws that are in the way have to come out of the way. But not only laws, also laws are written in the hearts of people. There's a law in the book, there's a law in the hearts of people. That is the social norms. Those are the things you learn when you are in your home, in the classroom, in the media, in the mall. Those are laws written in your heart about what is good and what is wrong. So we have to tackle attitudes too. We have to tackle beliefs. We have to tackle social norms. So this area of work is going to be an important part of our work in the coming 5 and 10 years. Because if we don't win on that area, there's no medical tool that is going to help us to walk the last mile, to win the battles that are remaining. The reason that most people can come forward and are on treatment is that they have their rights. The majority of people who have their rights are able to go and get prevention and go and get tested and go on treatment. But those who don't enjoy their rights are the ones still left behind. So rights, 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 human rights. And I am a hardened social justice, human rights warrior, and I am dragging everybody into this fight. We've got to fight them and win on the human rights of sex workers, of gay men, of men who have sex with men, of people who inject drugs. We've got to be on their side and help them to fight and win their rights before we can win the HIV battle.
Thank you very much, Winnie, for that. Dr. Vatiti is now online. Dr. Vatiti is a medical doctor as well as a person living with HIV and is chairman of the network of people living with HIV in Uganda. Dr. Vatiti, you have the floor, please.
Yes, thank you very much. And happy to be following all the deliberations. I would like to say we are very grateful that we've made progress. A lot of people are on ARVs. Still we have, but the question is, how do we ensure that those of us who are on ARVs continue to have good quality lives? Because beyond suppressing the viral load, many people are getting depression, others have other non-communicable diseases, and yet the program don't seem to care about this. They're just concerned about suppressing the virus. That's one of my concerns. That what do we do to make sure that people already in care enjoy good quality life?
Thank you, Dr. Vatiti. Maureen, would you like to take the first crack at answering the concern of Dr. Vatiti, followed by Winnie?
I think, first of all, I would want to bring out the fact that Dr. Winnie mentioned before. We focused on treating people and reduced our efforts on care and support and other prevention services. We have medicalized HIV. And HIV is not a medical problem. It has so much of social and cultural issues and political and legal that surround it. So just to broaden the response is that unless we widen our scope, unless we stop medicalizing HIV response, we will be mopping the floor with the tap open. And therefore, there's need for programs to focus on looking at the whole comprehensive aspect of the response and taking into consideration that just having drugs in the facility and people taking it and supporting adherence is not enough to get us to where we want to go and to get us back on track. So we have to make deliberate efforts. We have to look into how do we bring in the different sectors and give a comprehensive response to HIV. So when we see HIV embedded in a Ministry of Health program, we have trouble. We have trouble. So we need to look at our countries and really think through, sit back, go back to the drawing board and broaden the scope of response. Yeah, that would be my wide overview of the whole thing. Yeah.
Thank you, Maureen.
I love the way Maureen puts things. Mopping the floor with the tap open. I'll keep that and borrow it time and again. You're so right. I want to add to your comments. I completely agree with you and add on something about mental well-being. I think that services that people living with HIV need a wider, comprehensive package of services, including mental well-being. When you consider that someone is going to live off a tablet for the rest of their lives, maybe starting from birth, that is a heavy burden. And when you think that that person is living also in poverty many times and is hiding their secret because of stigma, hiding it from friends, from employers, this is a huge challenge on the emotional and mental well-being of a person. So these services should be considered as part of the package. But the fact that now it's narrowed to just now about the tablet, the ARV, just tells you that we are losing the battle. And I think many people who don't even come on treatment or don't adhere to treatment is because they can't cope with the emotional burden to deal with the stigma in the society. This needs professional care. So we need to fight harder on what constitutes the package of services for people living with HIV or the package of services for those at risk. I just want to agree so much.
Thank you very much, Winnie. On that note, we will have the last question from a person living with HIV, Pratik Rawal. Pratik, you have the floor.
Yeah, I am Pratik Rawal from Gujarat in India. And I believe that last sessions, the Marin is the stage, the HIV is the not a problem of the medical health, but also some issues arising, some different also. So in India is the during the COVID situation is the very tough, and that time is the partnership of the government and the people living with HIV/AIDS networks is very strong. And the first they were sit with the government and the during the lockdown situation how to reach to our people and giving the services of the ART is a very important role. And that time they are trying and planning the strategy how to reach the people living with HIV/AIDS and giving this not miss a dose of the ART regimen. And then time we have a very good program available in India is the VIAN project with the care and support program. The all outreach workers, TA partners, and targeted intervention program partners, and all the NGOs and CBOs are gathering, and they are going and implementing the strategy to deliver the ART. And then they are finding this ART is not only for the issue. They are the facing people with HIV is also facing during the COVID situation, lockdown situations, facing the nutrition also. So that time they are believing and resource mobilizing from the some NGOs, CBOs, as well as local donors, and mobilize the nutrition support to PLHIV also. And the government also taking the very good support to people living with HIV/AIDS and the PLHIs to access the ART medicine from the ART centers and the nearest ART center as well as at the for the home also. And during the time the PLHIVs as suffering the mentally stress. That time there is the some online sessions also arranged for that some specialist for the HIV positive peoples, and is a very good response. The communities will be come out from the COVID situation, but still COVID is there, but the peoples are not fearing about they are not getting the ART is not possible, but ART is possible at home also. This is the strength of the HIV positive networks and government both together working in this area, and people can survive with the ARTs during the lockdown situation. Also, HIV positive people networks, state level networks, national level networks, and they are going to some research on this, the phone calls and research based data also collecting with the support of UNAIDS India, and there's some reports also available in this situation also. How can then get you are getting or not? What is the situation? Many questions are there, and this simply is survey says that, and that get is a very good initiative by the networks and government of India, and good result we are seeing in the COVID situation for the HIV patients also. Thank you
very much. Thank you very much, Pratik. Winnie, I think what Pratik was trying to say was that the role of communities in the COVID-19 response has been very, very critical and very upfront. And they've managed to rally back and bring services even when the situation outside was very, very difficult, and put up their advocacy front. So closing remarks from you, Winnie, on the role of community and the way forward.
Oh, thank you so much, Mahesh. And I'm so grateful for this discussion with my fellow panelists and all of you who have joined. We really must see ourselves, much as COVID is having a negative impact on our work of fighting AIDS, and we must fight and fight and fight to keep our struggle going. we must also see ourselves as having important lessons, important strengths to bring into the COVID response. One of them we have discussed here definitely is the importance of the role of communities and the centrality of communities in an effective response. The other one we didn't touch on is about the multisectoral approach. And I think Maureen alluded to it, that HIV or any pandemic is not just a health issue. Just bringing the whole of government and the whole of society around a response is critical. We must continue pushing there, asking governments not to make COVID task forces that don't include our opinion leaders, our community leaders, women's rights leaders, plus, of course, all the economists and social scientists and epidemiologists. So this is an important thrust for us, and we bring it because we know how to work like that. So I really want to end on a positive note that let us see ourselves as important in the fight also of ending COVID and having important skills and lessons and knowledge to contribute there, and to see that we are going to fight on. We are not going to surrender in our own struggle to beat HIV/AIDS. We will redouble our efforts, rally around new targets, and find ways to take to scale all the positive things that we have learned. I want to thank everybody, and thank you so much, Mahesh, for conducting such a good discussion. Thank you all. Aluta continua.
Thank you very much, Winnie, and I would like to thank everybody for joining us today and for the vibrant discussions on the chat forum that's been happening both on YouTube and on the Zoom platform. A special thanks to Dr. Sultan and Maureen and Ms. Karg for joining us today. The report is available on unaids.org. You can download it. And a reminder that December 1st is World AIDS Day. The theme is Global Solidarity, Shared Responsibility. We have a set of social media materials and interesting videos on our website. So we request you to join the conversation, share the materials with your networks, and make the commemoration a success. With that note, thank you all for joining us. Have a good day, and goodbye.